as we open our doors. Again, good morning, good afternoon, and good evening to all our participants. This is Faruk, the International Pediatric Ophthalmology and Strabismus Council President. It is a delight to meet with all of you one more time in our monthly webinars. As always, the webinar is hosted by the American Academy of Ophthalmology, and I would like to especially thank Daniel Mummert and Michael Ray for all their efforts. While our world tour and journey continues, and this month we are co-organizing, as you know, our webinar with the Brazilian Society of Pediatric Ophthalmology, and it is a particular delight. And our IPOSC Childhood Visual Impairment Committee Chair, Dr. Vasconcelos, has been the architect for this Pediatric Low Vision webinar. It is a distinct, again, pleasure to be representing IPOSC. Now close to 90 membership organizations and more than 20,000 individuals are represented. And again, without further delay, I'm going to hand it over to the SBOP President, Luisa HOPKER, for her to say a few words, then we'll start the session again. Great to have you all in another fantastic webinar. Thank you.
Thank you, Faruk, and thank you all. Good morning or good afternoon or good evening, depending where you are. So I'm honored to be here among such great ophthalmologists. And the Brazilian Society of Pediatric Ophthalmology is very proud of having 3 of its previous presidents here in this webinar: Galton Vasconcelos, Celia Nakanami, and Andrea ZIN. We are a relatively small society, but certainly composed of outstanding pediatric ophthalmologists. Also, it's amazing to see great names here, such as Luciene Fernandez, Angela Fernandez, Clare Gilbert, represented by Aeesha Malik, and Rosario ESPINOZA, and Sirijana Adhakari, who was my partner in China a couple years ago. The world is really small. Just want to say a few words about SBOP. We have a current board of directors composed by me, Dr. Julia Rossetto, and Dr. Cristiane Rolim de Moura. And together with the past 2 presidents, Dr. Fabio Genbaum and Galton Vasconcelos, our society has been broadening its horizons. And this is a result of a very hard-working team. We have developed guidelines for the Brazilian ophthalmologists to base their practice. We have also have several webinars, just like this one, that I am so proud to be part of. And low vision is a very challenging field. I'm sure this program will enlighten everybody who's watching this webinar in order to provide best care for this population who has such special needs. So I would like to thank IPOSC and AAO to make this event happen. And I also want to thank in advance all these great speakers that we have today, and especially thank to Dr. Galton Vasconcelos. I hope you all enjoy as much as I will this great program.
Thank you, Luisa. Good morning from Brazil. On behalf of the IPOSC Vision Impairment Committee, I welcome you all to this webinar with such a fascinating topic, children's vision rehabilitation. I want to show my deep appreciation for fabulous people who push us forward. Sonal Farzavandi, Jason Yam, Faruk ORGE, and Daniel Mummert from American Academy of Ophthalmology. And this great team of moderators and speakers. Thank you very much. Enjoy the webinar. I will pass to the moderators, Dr. Andrea ZIN from Brazil and Dr. Angela Maria Fernandez from Colombia. They will explain the whole section, how it works. Thanks a lot.
Thank you very much. I'm Angela Fernandez from Colombia. I'm very happy to be here, and I'm so honored to moderate this webinar. We have fantastic speakers, and the first one is going to be Aeesha Malik in Epidemiology of Vision Deficiency and Blindness in Children Around the World. Then we will have Luciene Chaves Fernandez from Brazil in Clinical Pearls for examining a child with low vision, and Galton Vasconcelos, our dear Galton, with Refraction in Children with Low Vision. We are going to have the whole webinar, all the presentations together, and then we are going to start with the discussion. And please, my dear Andrea ZIN is going to present the other three speakers.
Hello, everyone. Greetings from Brazil. Good morning, good evening, everyone. So the next speakers will be Dr. Rosario ESPINOZA, that will speak on building up multidisciplinary teams for children with low vision, followed by my great and dear friend, Celia Nakanami, who will speak on vision rehabilitation in ROP challenges, and Dr. Srijana Adhikari, who will speak on visual rehabilitation in CVI and children with multiple needs. Enjoy, everyone, the webinar.
Incredible around the world. We have speakers from so many places. Please, Dan, we can start with the presentations.
My name is Aeesha Malik. I am a pediatric ophthalmologist based at the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine. And I work with Professor Clare Gilbert, who's unable to be here, so I'm giving the talk on her behalf. So today I'm going to be talking about blindness in children, the magnitude, the causes, and the priorities for control. So during this talk, I'm going to cover the recent estimates of prevalence of blindness, the magnitude and the causes from the Global Burden of Disease Study by region and globally. I'll look at the major avoidable causes overall and by region, any possible changes to these estimates and burden in the future, and what could be both priorities and opportunities for control of childhood blindness and visual impairment. So firstly, looking at the prevalence, magnitude and cause of blindness in children by region. Historically, there has been very limited population-based data for estimates of childhood visual impairment and blindness, and there has been a real paucity of evidence. However, there are two recent estimates from 2020 that can be used. So the first one is derived from using the under 5 mortality rates as a proxy for blindness prevalence in children from 0 to 15 years. This has been used as a way of estimating childhood blindness rates for the last decade or more. Secondly, there has been an estimate made by the Vision Loss Expert Group as part of the Global Burden of Disease Study, and that was done for the first time as part of the Lancet Commission on Global Eye Health. There is, however, no reliable data on number needing low vision care or visual rehabilitation. So this map shows the prevalence of blindness in children using the under 5 mortality rates as a proxy. On the left-hand side, you can see a table which shows the under 5 mortality rate, and next to it the column which shows a prevalence of the estimate of blindness. From that, you can see that overall, the burden of blindness in children lies primarily within sub-Saharan Africa and in parts of South and Central Asia. Now looking using the same estimates, we can look at the number of blind children in 2020, this time using the Global Burden of Disease super regions and looking at the prevalence per 10,000. So on the x-axis along the bottom are the super regions as divided up by the Global Burden of Disease Study. And on the x-axis is the number of blind children. And the numbers on top of the columns is the prevalence per 10,000. So here again, you can see that the largest actual numbers, so the burden of blind children, the highest numbers are in sub-Saharan Africa, followed by South Asia and Southeast Asia, with the lowest being in Central and Eastern Europe and Central Asia. So this gives in total just over 1 million, so 1.025 million children blind, and this excludes any uncorrected refractive error. If we look at this data in a little bit more detail in this table, we can then begin to see how the super regions are divided up. So under high income, you can see the different areas that come within that, including Western Europe and Australasia. Again, if you then look at Latin America and Caribbean, you can see different numbers depending on the Andean, Latin America and Caribbean regions, etc. Here again, it shows how the number of children in those regions, 0 to 15 years, the number of blind, and then the prevalence estimates. And these, again, come to that overall total figure that I showed before of 1.02 million. But this can be useful if when looking at your own areas to estimate what could be the prevalence of blind children within your own regions. Looking now over time, we can have a look at how that changes, what has been the change in estimates of the number of blind children since 1990. You can see in this column on the graph on the left-hand side is the number of children in 1990, which was around 1.5 million, and how that has gradually decreased over time and over the last 20 years to be at the current estimate, which is 1.02 million. And now if we turn to the second estimate of visual loss and blindness in children, this was the estimate made by the Vision Loss Expert Group for the first time in 2020. This looks at children 0 to 14 years old, as opposed to 0 to 15. And here the numbers that they estimated was blindness was 1.44 million children, but that did include uncorrected refractive error. You can see that the moderate to severe visual impairment was 22.16 million and mild visual impairment was 46.6 million. In total, this gave 70.2 million children who were visually impaired or blind throughout the world, which is 3.5% of all children aged 0 to 14 years. You can see from this that the two estimates of the blindness magnitudes are really similar. This is bearing in mind the different age groups, and also that, of course, the global burden of disease definition includes uncorrected refractive error, whereas that which is based on the under 5 mortality rates does not. So then we can come to think about why do we think that the estimated number of blind children is falling? And we can think that it's for these three main reasons and a combination of. So firstly, overall, socioeconomic conditions are generally improving in most countries and in most regions across the world. That then has also led to better control of childhood diseases, including measles and vitamin A deficiency. Therefore, the complications, ocular complications of those conditions has reduced. So there's been reduced corneal infections, reduced corneal blindness, and therefore overall lower incidence of blindness. This is happening overall, but more slowly in Africa than anywhere else. Secondly, there are more and better tertiary level child eye health services providing high quality care. This was one of the major aims of or targets in the Vision 2020 program, and this has shown results with more tertiary level services available for childhood eye problems. Thirdly, the total number of children globally is stable. In other words, it's not increasing as it has been for previous decades, and it has remained at around 2 billion, and this is overall due to falling birth rates. Again, this is happening more slowly in Africa than anywhere else. So then if we come to look at what are the causes of blindness by anatomical site in 2020, here in this table you can see there's a color coding which is right at the bottom. The sort of bright blue there is cornea. There's a kind of a dark green which is retina, and a more dark yellow which is CVI. The column on the left shows the percentages. Just looking at a couple of things on this graph, which is obviously quite busy, we can see that corneal causes of blindness remain relatively important in places like Sub-Saharan Africa, South Asia, and also Southeast Asia, but are very low in places like Latin America or in high-income countries. You can, though, however, see that cortical visual impairment is an important cause in high-income countries and in Latin America, but is less seen in other regions. And again, also retinal causes, which are often the hereditary genetic causes of blindness, are much greater burden in places like North Africa and the Middle East, Latin America, and Central Europe. So what are the main avoidable causes for blindness, and therefore the priorities for control? So uncorrected refractive error is obviously a very important cause that is very prevalent, particularly in Asia, also in Latin America, less so in Africa, but possibly increasing. Then there's cataract, which is prevalent across all regions. Then there's retinopathy of prematurity, which again has shown increasing prevalence in Latin America initially, and now also in Asia, and it's now beginning to be seen in Africa. Glaucoma is there across all regions. Corneal scarring remains prevalent in the poorest regions in Africa and Asia. And then overall low vision and totally blind children are there prevalent across all regions. Looking ahead to what possible changes may occur in the future with burden of childhood visual impairment and blindness, we are seeing that ROP is already becoming a cause of blindness in Africa, and this may become increasingly important there as neonatal care there expands. We're also seeing, interestingly, that the vitamin A deficiency and measles, which has been extremely well controlled and programmed over the last few decades, is beginning to falter in many low-income countries. And this has been exacerbated by the COVID-19 pandemic. So we may begin to see rates of corneal blindness increase in certain countries. And overall, as we see more children are being born preterm and survive, we can also see that there will be increasing numbers of cortical visual impairment. So looking ahead at the priorities for action, when we look at services, we know that 85%, so a large majority of blind children, are either blind at birth or become blind by 5 years of age. So this early age group and the primary care level is very important to detect and diagnose these children early on so that they receive the care that they require. This often needs red reflex testing for every newborn child, and also again at 6 to 8 weeks of age as a basic screening tool. Integrating eye care into the primary healthcare level for children is essential, or will be essential, to deliver these services at scale. Strengthening secondary level care is very important, as often in many countries where there is very poor primary care services, children will present for the first time initially to the secondary level. And building on some of the success of strengthening tertiary services by moving them outside capital cities and into other large cities and towns. And finally, connecting primary, secondary and tertiary care, and strengthening those links so that when children are detected with any abnormalities, they are able to find the care and get to the care they need quickly. Looking at more specifics, certainly ROP services will need to be developed in Africa and strengthened, and ideally using telemedicine models due to the long distances and the lack of ophthalmologists there. School eye health programs that are comprehensive and include teachers' eye health needs, health promotion, and children as agents of change are also a priority. And really looking at evidence of good models of care for low vision and visual rehabilitation using evidence-based interventions as well. There's a lot of opportunity at the moment and upcoming. Several eye conditions have been identified by WHO as priorities for control within universal health coverage, and there's many evidence-based essential packages which are being developed, including eye conditions in conditions countries' national health strategic health plans for child health and in primary health care could also have major impact. The whole integration of eye care into child health and primary health in general requires a lot of advocacy and has a real possibility to make change at scale. And the time to act on all of this is now. There's a lot of possibility post-Vision 2020 and with as changes and are occurring in WHO, as we've mentioned, with the universal health coverage. So I'm going to stop there. Thank you very much for listening and your time, and I look forward to being part of the discussion and also answer any questions. Thank you.
I'd like to thank Dr. Vasconcelos, for whom I thank the IPOSC-SBOP, American Academy of Ophthalmology, for the invitation. I will be discussing here some clinical purposes for examining a child with low vision. Two things are very important to remember. It's a visual system is in development and lack of normal visual experience. So early identification, diagnosis, and treatment are essential. 78% of children diagnosed as blind have some residual vision, so it's important to careful evaluation. Treatment depends on the severity and type of eye conditions, the age of the onset of impairment, the ability of the family to cope with the disability, and the involvement of the transdisciplinary team. The low vision evaluation is essential for vision rehabilitation program planning. Multiple consultations are often required to obtain reliable data and diagnosis. The assessment should be arranged for time that are optimal for children, bedtime, medication, alertness. It should be based always on the child and his or her needs. The low vision evaluation begins when the child enters to the room. It's an informal evaluation. Much information can be gained from careful observation of patients' performance on a variety of visual tasks as posture, head position, visual curiosity, nystagmus. Does the child trip over or bump into object or find them easily in a room? Does the child look around? What's the attitude and direction of the family members who accompany the child? And so many other things. The functional history is essential in rehabilitation programs. It reveals how patients are using the remaining vision. It gives insights into adaptation they are already making. It is an important moment of interaction among ophthalmologists, child, and family. That is very important for success of vision habilitation and rehabilitation program. Assessment of the remaining visual function is a key component of low vision rehabilitation we will be discussing here. Fixation, the ability to develop with the visual experience. The quality of the fixation is evaluated. It is evaluated by object of various size and type as in high contrast and different colors illuminated according to the child's age and interest. Fixation can be stable, unstable, lacking, central, or eccentric. Together with fixation, other visual functions should be considered: eye and saccadic movements, binocularity, accommodation, convergence, presence of nystagmus, hand position, strabismus are also evaluated for each case. Children with severe motor disabilities have more problems with their oculomotor functions than other visually impaired children. When objects are fixed binocularly, they emerge formed in corresponding areas of the two retinas, forming a single image with the same size, brightness, and shape. Binocularity promotes simultaneous perception, fusion, and stereopsis. It's compromised in low vision patients, especially when the visual acuity is less than 0.1. The development of accommodations may be delayed in patients with low vision, especially with cerebral palsy, Down syndrome, and other situations. It will be checked by static and dynamic retinoscopy. This is a very important point in low vision evaluation children. It's important to check both static and dynamic retinoscopy. Insufficient accommodation needs to be compensated with reading glasses, plus 2.5 to 4 diopters to visual stimulation. Visual acuity, as you know, is the visual ability to resolve or recognize fine details. But this is not the same as the ability to detect objectives. It should be evaluated monocular, binocularly to evaluate dominance, binocular performance when you have an improvement of 10%. And with and without best corrected refractive errors, evaluation, prescription, the necessity of the prescription. When the visual acuity is less than 0.1, low vision aids are prescribed early, but when the visual acuity is better than 0.1, they can be prescribed after the first 2 grades, of course, consider each case. The methods that should be appropriate to the child's level of understanding. Sometimes a smile response to a stimulus can be considered an indirect sign of a visual perception. When necessary, you can bring the child closer and try to identify visual field reminder. Great acuity values are often significantly better than optotypes acuity values. Point at the optotypes, change the test, and misleading good visual acuity values. Pay attention to this. As Dr. Fletcher always says, patients looks at his scotoma, so observe the patient's attitude. Visual field symptoms are related to disease, size, location, density of the scotoma. Methods should be appropriate to the child's levels of understanding, and functional evaluation is necessary to complement them. A binocular performance improves the visual field. Central scotoma, less of detail, is difficult for reading. Usually you have good response to low vision aids. Peripheral field loss, as Dr. Lifari refers as cornea vision, can manifest itself in orientation mobility problems rather than reading problems. There is a limited response to magnification, the same things that the diffuse loss of visual field when you need to prescribe video magnifiers. Eye movements increase the functional size of the visual field. It's important to recommend it. Contrast sensitivity is one of the most important measurements in the assessment of visual function. Poor low vision contrast significant difficulties in activities of daily living and face recognition. We have different tests. The World Health Organization recommends hiding height, LH, and perioption to be included in low vision evaluation. It should be elected for each case. As the contrast is reduced, subject needs to be larger and a better illumination is necessary. We see very small details only at the right contrast level, right? A very low contrast sensitivity makes it difficult to adapt to optical aid, particularly telescope. A binocular performance increases the contrast sensitivity in 40%. So try a binocular performance whenever it is possible. Refractive errors are the leading cause of visual impairment around the world, as you know. They contribute to accentuating an already existing vision loss. Do not relate the low vision only with the pathology. A careful reflection prior to the prescription of optical and electronic aids is necessary. Uncorrected refractive errors can reduce acute and contrast sensitivity and give misleading results in central visual field. High refractive errors and anisometropia should be corrected as early as they are detected to try to prevent further amblyopia, as Dr. Vasconcelos will be explained better. It's important to keep a near vision task. Low vision aids needs goals change as children grow older. The assessment must be modified according to the developmental age of the child. Prescription of devices should be made based on the child's needs and goals and visual functions such as visual acuity, contrast sensitivity, and visual field. Goals and objectives should be realistic and attainable with the participation of the child and his and her family. Success comes only when children are active participants in the rehabilitation process. It's very important. High plus spectacles are often rejected by children because accommodation that gives them a clear image at the close distance without them. Stand magnifiers are well received by children and are often the first aid prescribed. Telescopes that are suggested for first prescription are the handheld monocular 2.5 to 4 axis. Video magnifiers are recommended for large magnification when the child does not respond to other aids. Absorptive lenses may increase with contrast to reduce glare and improve acuity, but not a very dark one for children. All the devices need training for their best see, and follow-up is essential for a successful rehabilitation process. The early rehabilitation, the early adaptation, the lower the consequence on the children's life. The participation of the patient and the family is essential. There is always something to be done for the child's self-esteem, their education, and social inclusion. Thank you.
Good morning, everyone. I have no financial conflicts to disclose. Firstly, I want to emphasize the importance of refraction to decrease global vision deficiency and blindness and minimize low vision. According to Sunis, in an adult low vision study published at the Ophthalmology 2010, refraction may often be overlooked in low vision patients when they only emphasize the causes of low vision. They found 11% of a sample with macular degeneration, they improved 4 lines of vision acuity, and in some cases, the worse seeing eye may become the better seeing eye when glasses are prescribed. So I can suspect that the same would happen in children. What would be the adequate refraction for children with low vision? So let's see some points. We're facing major challenges. We are dealing with babies and children in visual development phase, and the threat of irreversible visual impairment is always present. So pay attention to the Leah River and the 4-leaf clover, landmarks for visual development, communication and interaction, activities of daily life, orientation and moving, sustained near vision tests. So bear this in mind when you are considering prescribing the ametropia found. So why it is important, the prescription and refraction? Due to the high prevalence of high ametropias and anisometropias. Yes, they may be very high ametropias, and its association to visual field deficits, binocular visual field deficits, strabismus, nystagmus, contrast and color discrimination deficit. The correction of refractant errors may improve color discrimination, contrast, and reduce glare, even though the child may not gain visual acuity lines. Whenever transparent media is present, a retinoscopy is possible. So try to correlate pathologies with transparent media and retinoscopy. When retinoscopy is not available, we can try 3 tri-lenses, or when the medias are not transparent, for example, congenital glaucoma and corneal haze, we can correlate congenital glaucoma and myopia, for example. We know that accommodation and brain damage is correlated. According to Dutton, only 42% of children with CP have normal accommodation, and they may have reduced accommodative amplitude up to 4 diopters. Also, slow pupillary light responses may correlate with accommodation deficits, so pay attention to the pupillary size when you're performing your dynamic dry retinoscopy. So after correlating dry and cycloplegic refraction and the amount of accommodation present, if there is accommodation deficit, we can choose or overplus lenses, +2, +3, plus the distant refractive error, or the use of bifocals in those patients where there is a good neck control and good gaze control. Children with Down syndrome may under-accommodate, and we have to consider prescription of lenses. But in order to adapt glasses to those patients with Down syndrome, we have to consider the cognitive deficit, if there is neck hypotonia, the low implantation of the ears, the small nose size, and the impulsivity. So we're going to choose overplus lenses or bifocals. Galton and collaborators have shown that Down syndrome patients may benefit and they have good compliance when they use bifocals for accommodation deficits. It is quite important to think about adequate frames and lenses, good materials that fit perfectly to the nose and to the face, lightweight and long-lasting materials. I'm going to present some details. When on prescription of glasses, take into consideration the initial pathology, and developmental stage. Remember, inotropias may be commonly overlooked, may be hidden, so check the extremes, +20, -20, +15, -15. When thinking about myopia, think about the world of near activities the child has. So we can consider undercorrection for those younger children. Remember, negative lenses minimize the size of image. This may be important when you have large scotomas, for example. When you're thinking about hypermetropia, take into consideration age, developmental stage, and association to strabismus, nystagmus, and of course, if there is lack or under-accommodation. When prescribing astigmatism, for those children with vision impairment, even small amounts can be useful. If you're not very sure about the amount of astigmatism or the excess, reschedule the patient and try again. Usually, those patients will need constant reviews and discussion among members of the team. To conclude, the success of the rehabilitation process is also dependent on the quality of refraction and prescription of correct lenses. Ophthalmic interventions for children with low vision should always initiate for the correction of anotropias and accommodation deficits. Dry and cycloplegic retinoscopy should be performed in all children with low vision who have transparent media. I thank you very much.
Good morning. I am Dr. Rosario ESPINOZA, and we talk about building up multidisciplinary teams for children with low vision. I want to thank Dr. Galton Vasconcelos for inviting me to the important event. There is no conflict of interest in this presentation. Why working in multidisciplinary teams? Remember, vision is a learned function. Learning is created through experiences. The child learns to reach an object, learns to reach a person, learns to crawl under furniture, learns to climb onto different objects. It starts discovering their environment through wandering around and develops spatial perception. If the child uses their vision more, it will work more effectively. In order to achieve autonomy, the child needs the optimal central nervous system, needs to have motor, cognitive, language, social, and emotional development, which has to be balanced, all of them. The child needs integration of all senses, needs integration of other aspects such as environment, motivation, and participation. For example, movement is acquired because of interest, imitation, social behavior, etc. but there must be active participation. And what about what happened with the low vision children? They have few visual experiences. Disturbance in mother-to-baby bonding. For example, might not recognize their mom's face, have greater difficulty in visual integration because his visual perception is affected. Also has disturbance in imitation. For example, in the games, inside, out, top, down. Can have language disorders also. And disturbance in anticipation is frequent. For example, the low vision child cannot anticipate if mom comes to bring the bottle of milk. If they don't achieve to anticipate, it will cause them anxiety. As a result, they are more exposed to frustration and fear. On the other hand, parents are usually overprotective, which can take away opportunities, or overstimulated them, which can lead to stress. So, our work is enough? Dear colleagues, will our approach to low vision children be complete with only ophthalmological management? It aims toward the visual area, but mainly to favor global development. It should be approached in a playful and functional way, considering the children in their entirety. Always from a biopsychosocial and educational perspective that includes the environment and multidisciplinary team. What is this? We need ophthalmology, optometrists, visual therapists, or occupational therapists, physiotherapists, and psychologists. It is very important covering all areas of development. It includes motor, cognitive, communication, socialization, and personal autonomy. So, we should work as a team, sharing our experiences with child, the new skills, and their future. Thank you for your attention.
Good morning, everyone. Thank you for the IPOSC organizing committee. We know that treating RP lesions is essential for prevent blindness, but besides that, much remains to be done after discharge. So what do those babes need after that? Babies with RP, treated or not, they have many ocular disorders, and some of them are also associated with systemic, especially neurological comorbidities as CVI. In this way, put them at risk of irreversible visual loss. Abnormal visual stimulus at early age in a critical period will affect the global development, and given the complex of ROP, many other areas of development are involved, make those children take longer to approach development milestones. Due to the lack of acquisition of concepts, these children will depend on professionals to help them for growth, cognition development, and get skills on learning, orientation, mobility, language, and others. And they should be referred for a low vision service and followed by a multidisciplinary team in an early visual stimulation program. So we will, it's very important to control the visual acute level, the gains and even losses using appropriate methods, not only to identify and classify the low vision, but to control the level. We will assess how is the child's visual contact and the fixation parameters for age. It's not uncommon we detect that the child is unable to fix centrally and prefers trying to fix bilateral gaze. These children need to learn to fix, how to fix, to accommodate, to convert, and to follow. So prescribing glasses is essential. Myopia is prevalent in children treated or not with ROP, and myopia is less prevalent in anti-VEGF eyes treated than laser photocoagulation, but is still remains high. Maybe the preserved peripheral retina allow the emmetropization process. And in case of cerebral palsy, we know that reduced the accommodation occurs, and consider to prescribe plus edge lenses. So strabismus is very prevalent, and sometimes it's a stable deviation at the beginning, and if CVI is present, exotropia is more prevalent, and a dyssynetic strabismus with a variable angle is present. Exotropia can evaluate to exotropia spontaneously, and the correction of strabismus is important because it improves self-spatial and motor perception, and also visual motor function. In small angles, up to 25 or 30 prism diopters, toxin botulinum is very good indicated, and we have good results. Sometimes pseudoesotropia due to a macular dragging is present, but there is no treatment for that, of course. And if torticollis is present, maybe it's compensatory in order to obtain binocular vision or block nystagmus, or sometimes for visual field loss like hemianopsia. In contrast, sensitivity loss, children have difficulty in figure ground segregation, such as find things, orientation, and mobility, walking on different shades. So the solution is to expose the child in a sort of shades in different situations, up and down stairs, find objects. in vision, color impaired difficult. Sometimes it's difficult in routine skills like eating certain things and change clothes, and because they have more attention to bright colors, prefer work with opponent and bright colors. Because many cases is associated with CVI, start from simple to complex activities in a clean environment, clean fundus without many objects, not crowded, in order to make the child to find objects, toys, and beginning with a high contrast stimulus and objects. Provide experiences and train eye-hands coordination, make the child touch the toy that approaches to them, touch faces, hands at different distance, depths, train scanning the space around her. It will help them. Ocular disorders as several insults explain loss of visual fields, and especially when periventricular leukomalacia is is present, and we know that peripheral scar due to laser photocoagulation treatment also explain the loss of visual field. The confrontation visual field test is useful, and we can many times stimulate the fixation, and from this point train to keep the fixation and to extend the attention for other fields of gaze. Knowing the defect helps a lot in the adaptation of optical and non-optical resources. Child only learns what he or she lives concretely. So situations regarding to eating food, personal hygiene should be explored and experienced. For those children with severe visual impairment or blindness, intensive training for orientation and mobility provide the child to walk, to get independence and opportunities to participate in the environment where the child lives. Those children will grow up and continue their development and school learning. So new challenges are expected by students with the intention of obtaining the maximum academic performance and learning skills. So low vision is reversible, but vision continues to develop in a low process. And there is no much evidence in the literature that recommends us how to work with those children with low vision due to ROP. But the aim is to provide and facilitate their global development. In this way, low vision rehabilitation can provide better quality of life. Congratulations to the IPOSC for the initiative to stop infant blindness in Africa, and thank you for your attention.
Good evening. Thank you very much, IPOSC and Brazilian Society of Pediatric Ophthalmologists for this invitation. I will be talking on visual rehabilitation in CVI and children with the multiple needs. There is no financial disclosure and conflict of interest. The cerebral visual impairment is defined as a bilateral vision loss resulting from damage to retrogeniculate pathway in the absence of damage to anterior visual pathway or any other ocular structures, one of the leading causes of visual impairment in children. The term visual impairment is preferred rather than the term blindness, as the central nervous system is still plastic and presence of extrageniculate striate visual pathways precludes total loss of sight, and even when there is complete destruction of the striate cortex. So this has been changed from blindness to visual impairment, and in many places cerebral is preferred over cortical owing to the subcortical involvement of optic radiations in the premature infants. So it can result from the insults at the level of cortex, which includes geniculostriate lesions, and subcortex, which includes focal white matter lesions resulting to periventricular leukomalacia. There is a delayed visual maturation can also result from a temporary dysfunction of higher cortical centers. Many of these children have delayed milestones of motor and sensory development. The etiology of cerebral visual impairment ranges from structural anomalies of the brain to the neurological disorders, with a long list of vascular lesions, infectious, inflammatory lesions, trauma, metabolic conditions, etc. The characteristics of infants with the CVI includes variable, poor or atypical response to stimuli, eccentric viewing, latency, preference for familiarity, light gazing, color preference, difficulty with complexity, preference for certain visual fields, and better visual performance with the movement. While on the other hand, the characteristic of older children with the CVI include slow and inefficient visual performance, a deficiency of visual perception and integration, contrast sensitivity impairment, difficulty with complexity, short visual attention, poor visual memory, difficulty with object recognition or face recognition, and expressive delay. An approach to patient with the CVI, it always starts with history and of course examinations, which includes visual acuity, pupillary reaction, anterior and posterior segment, alignment and motility, and cycloplasic refractions. History should be very careful to localize the etiology of cerebral visual impairment. Other things to see are accommodative amplitude, visual attention, fixation or visually guided behavior, latency, saccades pursuits, and contrast sensitivity. The assessment of vision and visual functions can be challenging, and visual impairment and in CVI can be as severe as no light perceptions to normal visual acuity. Vernier acuity has been found to be more affected than the grating and the reduced contrast sensitivity. The hypermetropia is a common refractive error and can be due to accommodative dysfunctions. Infantile exotropia is more common as compared to esodeviations. However, in children with the periventricular leukomalacia commonly present with esotropia. The optic atrophy due to hypoxic injury to the optic nerve or secondary optic atrophy due to the hydrocephalus can be there. The visual field defect is another important characteristic features of CVI, in which most of the time inferior field defects or homonymous hemianopia can be present. The BEP, EEG, and visual field tests are important investigations in diagnosis, prognosis, and monitoring recovery in children with CVI. The visual recovery, there is some degree of visual recovery is seen in majority of children with cortical visual impairment. The improvement tends to be gradual over months, although exact mechanism is unclear. The degree of recovery cannot be predicted from imaging studies. The visual rehabilitation should be multidisciplinary team approach, as there is a need for vision therapy as well as physical or physiotherapy. So parents and family there should be the involvement of parents and family, primary care physician, pediatric ophthalmologist, neurologist, educational specialist, physical therapist, speech therapist, and the teachers of the visually impaired and hearing impaired children. So must take into account other associated developmental issues whenever we plan for visual rehabilitations. There should be another associated developmental issues also should be taken into account, and most of these children have global developmental delay. The treatment and rehabilitation needs to be specific and aimed at individual requirements. Timely intervention and reassessments are very, very important. The treatment of systemic diseases, refractive corrections, treatment of accommodative insufficiency, amblyopia management, strabismus corrections, treatment of associated ocular diseases like cataract should be in all these conditions, there should be timely intervention. the phases of CVI, the phase is a period in the resolution of CVI that indicates degree or severity of CVI. There is mainly 3 phases, phase 1, 2, and 3. The phases are very useful in planning for appropriate interventions and environmental accommodations. There are individual education plans and individual family service plans are available for rehabilitation to assess the rehabilitation needs of children with the CVI. And this is an example of one form in which by observing the various behaviors in the children with the CVI, there is a scoring system, and then we can classify, group the children in different phases. And in the scoring, like for example, 0 to 3 scoring is phase 1, 3 to 7 phase 2, and 7 to 10 phase 3. So phase 1 is basically the severe impact on visual functioning, the phase 2 moderate impact on visual functioning, and phase 3 is closest to the typical visual functioning. So the G and Galton CVI inventory for higher function is also available, in which sometimes if it is difficult to identify the children with the CVI, there are 5 screening questions in which 3 of 5 suggestive of CVI, like in the history of difficulty in walking down the stairs, not seeing for visual, but not for the motor reasons, and not seeing things that are moving fast, such as small animals, not seeing something pointed out in distance, difficulty in finding item in pile of clothing, difficulty copying works or the pictures. So these are some of the points in which helps us identify the children with the CVI in different phases and to identify their different rehabilitation needs. And in phase 1, which is a severe form of CVI, in which there should be a simple environment with a decreased lighting and noise, present the child in a toy that is one color and has some movements. The toy should be introduced in a variety of visual fields, and give the child to respond. And wearing black shirt and having the children lie on the plain blanket or mat to decrease the complexity. So the complex environment should be reduced. And then again, slowly moving towards the phase 2, the couple of colors can be used, and the movement and the objects be shiny. There might be still visual field preference, and so we have to be very careful. And the children may be slow responders even in this phase also. And the children might, unlike in phase 1, the children might be able to tolerate some people when they are in a good mood, and have a child crawl towards a red ball and put it into a yellow container. These are some of the activities. And when going towards the phase 3, there is a good recovery phase, and in which the children are in a not very severe in its stays, and objects of the different colors can be given, and difficulty with objects with a lot of detail. The children can prefer, there is a preference of colors can be there, and then the placing the red color tape around their bedroom can help them move a wheelchair through the doorway. And they still might need movement or signiness of the objects and need someone to describe conditions. So these are some of the things that we can keep in mind in different phases of the CVI while doing the rehabilitations. And there are specially trained teachers or vision therapists can be employed for all the rehabilitations for providing the rehabilitation for the CVI children. So there is another rehabilitation therapy, that is perceptual learning therapy, which is popular, and there are some studies in undergoing in children with the CVI, and there is one study that we are undertaking is a restoration of visual function in children and young adults with cortical visual impairment by a perceptual learning that targets specific brain areas, where we aim to harness the plasticity of child's brain by rehabilitative training and use specifically designed visual stimulus to target the visual pathway. These are especially the moving visual targets, and then and moving visual targets with the perceptual learning training that we are conducting in our center, and the results are yet to be analyzed. And another thing is the children with the special needs are because of another entity is the cerebral palsy. And cerebral palsy is a group of disorders that affect a person's ability to move and maintain balance and posture. The cerebral palsy is caused by abnormal brain development or damage to the developing brain that affect a person's ability to control his or her muscles. And there are spasticity, dyskinesia, and different types of cerebral palsy is there. And the visual impairment in CVI can be in the cerebral palsy can be CVI, refractive error, accommodation, insufficiency, strabismus, visual field defects, and impaired stereo acuity. So in child with a spastic dysplasia, most of the time lower visual field impairment is present, and while in children with hemiplasia, homonymous hemianopic field defect, and child with dyskinetic cerebral palsy, impairment of accommodation is common. The question inventory has been designed to elicit evidence of visual field impairment and perceptual and cognitive behavior in children with cerebral palsy. The rehabilitation challenging in children with the cerebral visual impairment in association with the cerebral palsy. Timely treatment of associated visual problems should be conducted. And another entity is the autism, which is a related entity. And then autism, as we all know, is a very common disease these days, and it refers to the broad range of conditions characterized by challenges with social skills, repetitive behavior, speech, and nonverbal communication. And each child with autism has a distinct set of strengths and challenges, and some require significant support in their daily lives, while others may need less support and in some cases live entirely independently. So visual impairment is characteristically underdiagnosed in children with the complex needs, as can be the sign, as it is difficult to delineate. So diagnostic overshadowing, where one condition may mask another, is common in people with intellectual disabilities. So undetected visual impairment are likely to impact quality of life, stress level, repetitiveness to a new information, and therefore the behavior of individual with autism. Moreover, on the flip side, the children with the severe visual impairment suffer deficit in social and relationship development similar to observed in children with autism. Refractive error is common. Strabismus is more prevalent in autistic children than the normal population, and the study on the blind children have shown that higher prevalence of autism than the normal population. So take-home message is children with a cortical visual impairment and other special needs have associated global developmental delay, delayed sensory and motor milestones of development, cerebral palsy, or autism. These disorders have a spectrum of manifestations from mild to very severe. Rehabilitation needs should be assessed for each child individually. A multidisciplinary approach is important in visual rehabilitation and making most out of their ability in these differently abled children. So these are some useful resources. And thank you so much for your kind attention. Thank you.
Thank you very much to our speakers. They were all fantastic. We have some minutes for questions, and I will go with Dr. The first presenter. Andrea is also my co-moderator, and we're going to start asking the questions. But I want first to congratulate IPOSC, thank the American Academy. And we had people from Portugal, Reno, Nevada, Philadelphia, Cleveland, Vermont, Colorado, Indiana, Russia, Chile, Arauca, Colombia, Argentina, Brazil, Indonesia, Turkmenistan, Hong Kong, Romania, Mongolia, Netherlands, Costa Rica, Belgrado, Saudi Arabia, Bangladesh, Malaysia, Nigeria, India, Greece, Brunei, Paraguay, and Ukraine. Thank you all of them for attending. And Andrea, you want to ask the first question to Dr. Aeesha?
Yes, thank you very much for all the speakers. I was here paying really great attention because, you know, we deal with children with low vision, but sharing the experience for such, you know, experience as speakers is I was kind of paying attention. So I would like to ask Aeesha, as most children become blind before the age of 5, what does this mean in terms of impact on the child and society?
Thank you for the question, Andrea, and also thank you for having me and for having me represent, obviously, Professor Clare Gilbert, who's very big shoes to fill. So yeah, thanks for the question as well. I think it's really an interesting one, and it's quite an important one to answer, especially for all of us in terms of advocacy within our own countries and areas. And I think that is a really key figure, is that really the number of the children who go blind, most of them are happening before the age of 5 years old. So this kind of importance of really including eye health in children's health and the importance of the integration of eye health in child health is really critical in terms of our services. And I think also in terms of the child itself, you understand that blindness or vision impairment has an impact not only throughout their childhood, which then impacts their education, but then impacts also their job prospects, their future financial prospects. And so it's a real impact over their lifetime. And furthermore, with children, as we know, that it's not just the child that's being affected, but it's also their family as well. So I think these things are really important, and things that I think probably we all know quite intrinsically working in pediatric ophthalmology. But I think this is something that in general is an important message for us to get out there. And always in terms of when we're discussing child eye health, always talking about things like the number of blind years, to make that sort of distinction between the difference between the impact on adults and adult eye health, but also in children's eye health, and how that really has a much longer term impact for both the child and then a much wider impact in terms of the society as well.
Thank you very much. I would just like to make a small comment on your presentation. You've mentioned red reflex. We in Brazil have quite an experience now. And what we see, pediatricians, they are doing the red reflex. They are recognizing the abnormalities on transparency eye structures. But the real challenge now is access to eye care services. So it's an ongoing question. Thank you very much, Aeesha. It's nice meeting you.
Yeah, nice meeting you.
Thank you. Dr. Luciene, we saw your presentation, fantastic. And we would like to ask you, please, when do you recommend a low vision aid in a child?
Okay, thank you, Dr. Angela. It's a very important question. You know that children words is limited to gross objects. So it's difficult to identify a low vision loss. So it's important to pay attention to the needs and goals of the children. How does the children do their activities of daily living? How do they have the experience at the school and they live activities? So you recommend the low vision aids when the children can't do the things that is important for them. You know that children has a good accommodation. So when they bring things closer, they can see very well. But when after 2 grades, especially when the visual acuity is less than 0.1%, 0.1, it's difficult to accommodation so much. So it's important to consider the needs and goals of the children, the visual function, visual acuity, and contrast sensitivity, especially because it interferes with the functional vision. So you recommend aids for children, combine needs and functions of the children.
Thank you very much, Luciene. I would like to ask Galton a question. And how much of myopia under correction do you prescribe for children, and how it is done in different ages?
Yes, thanks for the question, Andrea. This all depends. I learned from the psychotherapists that we should pay attention to children's arms because it's the length they're going to achieve the objects they're going to touch. So the smaller they are, the younger they are, we can make them to see very clearly at near. So I would say in terms of numbers, I would say in between 2 and 3 diopters. So if they have only 2 or 3 diopters of myopia, I leave them uncorrected. As they grow older, they will need more to see at far. So we can reduce the under correction for myopia. Let's say 4 years old, 1 diopter less, 1.5 less. And when they achieve reading and writing, they will need the far corrections at distance. So we have to reevaluate and see what we're going to do at up close if they're accommodating well. That's why we start the charts from near, reading charts from near when they are around 4, because we need to know how they read and how they perform with classes, more or less like this.
Excellent, Galton. Thank you very much. I have a question for Dr. Rosario Espinoza, and we would like to know, Dr. Espinoza, what is the role of the educator in the multidisciplinary team for you? Could you open your microphone? Okay. Open your microphone, Dr. Espinoza. Thank you.
Sorry. Okay.
Now you're on.
Yeah. The role of educator is key to the inclusive education. All the topics learned in visual rehabilitation should be reinforced in the school. For example, the uses of the lenses, optical devices, non-optical devices, and so on. The success in educational inclusion will depend on teamwork, on family context, and school environment. The visual therapist delivers a detailed report to the educator about the different details, for example, the size of the word that the child can see with only the lenses or with the optical devices, the distance to the blackboard, and so on. Thanks.
Thank you very much. And Celia, in underprivileged area, how do you start a child visual rehabilitation? Turn on your microphone.
Thank you, Andrea. Well, when we are working in an unprivileged area without tertiary care, eye care service, so we know that secondary eye care service can already do a lot for patients with low vision. So ophthalmologists, general ophthalmologists that can diagnose the cause and also other comorbidities, and starting with a complete and good exam or eye care exam, including refraction, and prescribe the optical correction. That's it's essential. So it's important to have basic concepts of low vision, to recommend parents and families, and what is low vision, what can we do for children with low vision, and what does exist about support other professionals of health to work with them, okay? To work together for their developmental, normal developmental, or approximate for the normal parameters, okay? So, of course, in advanced cause of ROP, for example, tertiary eye care is essential. And let me remember that tele-rehabilitation is a possibility, a real possibility, and it's a support for secondary eye care services.
Excellent, Dr. Celia. For Dr. Srijana, what is the prognostic factors for visual recovery in CVI for you, doctor, please?
Yes, it's actually, it's very difficult to predict the prognostic factors in CVI, but sometimes even the MRI lesions or any type of insults or any associated systemic anomalies cannot predict, but still when we see clinically the children, some of the children can develop very good vision, like the useful vision, like 2x60, 3x60 visions, and those children who are I can say that those children who are doesn't have much of the other developmental issues, those children and the children who have good vision in the starting can have good prognosis later in the CVI CVI patients, and those children with the global developmental delay and other developmental issues like motor or sensory developmental delays can have a little bit poorer visual prognosis. But as the child's other motor developments are also improving, in those children, the visual development also improves. So
thank
yes.
you. Just a quick question for you. How frequently should children be follow up?
Yeah, that is one question. Like just like I explained, we have to monitor the different phases of CVI children during their rehabilitation process, and then we can closely monitor them and maybe whether they are going towards improvement, and then follow-up can be done from 3 to 6 monthly, and or depend upon their improvement from one phase to another phase, because we have to change our rehabilitation techniques a little bit. That's why we have to monitor that, and usually in initial times maybe 3 monthly, and maybe after some times we can just monitor 6 monthly follow-up.
Thank you so much. I think we are just on time.
Thank you
for closing with our guests and our presenters, Dr. Galton, Dr. Jason, Dr. Faruk. Thank you so much to my co-moderator, Dr. Andrea ZIN from Brazil. It's a pleasure to see all of you here. Thank you for the attendance. We have also España, and we also have, I can't know, another country. Nepal, yeah, I mentioned. So thank you so much.
Thank you. Thank you so much for the opportunity. Thank you.
Thank you.
Thank you. So I would
Thank
like
you
to
all.
make an announcement for our next webinar. I hope you all enjoy the current webinar. Thank you so much. For our next monthly IPOSC webinar will be done with Turkey, the Turkish Ophthalmological Association joint webinar. And the topic will be current concept in strabismus and amblyopia. It will be on January 8th, a Saturday on 2022. It will be on 9 a.m. EST. We will have our president, Faruk as our moderator, and Cuban Attila from TOA. And we have wonderful speaker. 6 speakers. The first one is update on pediatric amblyopia study from Mike Rapka, United States. Second, unusual congenital restriction, how to handle the problem from Seyhan Özkan, Turkey. Complemental strabismus surgery from Fadras from United States. What does evaluation of accommodation tell us? Dennis Soma, Turkey. Torsional tractional test from Steve Kraft from Canada, and superior or inferior transposition in Duane syndrome from Kuma Sena, Turkey. So I wish you all to not to miss this wonderful webinar on January 2022. So looking forward to have you all in our next webinar. Thank you. So Galton, do you have wish to have a final word?
Thanks, Jason. Well, I was amazed to see all those attendees. I want to thank you all, the people from all different countries. And I hope this will bring more information. And it's simply to start from small. Someone has asked about where should we start? So we should start from small goals and make them bigger. You know, have to dream bigger in terms of low vision and the future of those children. Thank you very much, Jason.
So thank you. Let's end this webinar. Thank you very much.